certain inflammatory on eosinophils in asthma. You can see that the number of eosinophils, I presume these are in bronchial washings, pardon me, in the epithelium, the lining cells, drops with inhaled corticosteroids over 3 months. Also, the eosinophils in the basement membrane and in the connective tissue in the airways generally drops with inhaled corticosteroids as well. This slide is an important illustration of the number of canisters of inhaled corticosteroids per year. Most of these inhaled steroids last for about a month for a patient. So if a patient is very compliant and takes their inhaled steroids and gets 12 refills over a year, you can see that the death rate is very, very low. Patients who do not use inhaled steroids, the death rate with asthma, the death rate is pretty impressively worse. Another slide that shows the basement membrane is thickened, this is before and after. You can see the round cells, these eosinophils, the basement membrane is thick over here, and here you see the epithelial cells are regenerating, and these two slides are really not in the same scale, but basically there's inflammation before and less after. This looks at different medications in different age groups as far as the risk of hospitalization. The beta agonist, you can see that the more beta agonist prescriptions that are filled, the higher the rate of hospitalization is. These are talking about the short-term beta agonists like Ventolin or Proventil, albuterol. You can see that this is exacerbated, even more exaggerated in younger patients between the age of 0 and 17. With inhaled corticosteroids, you can see that the more canisters that are used per year, the less the hospital rate is. You can see a pretty good drop-off initially, but it's not as dramatic as you go out. Other anti-inflammatory medications that are not cortisone include Intal and Tylate. Long-acting beta-2 agonists are controlling type medications. Ceravent and a new medication coming out this month, Foradil, are inhaled beta-2 agonists that are long-acting, last for 12 hours or so. Volmax and Proventil Repitabs are really just a pill form of albuterol that is a sustained release and lasts a long time. Asthma is a disease of the airways, so if we treat the airways fine, you get good results. When you treat the whole body, you have side effect profiles that go up with more tremulousness, shakiness, rapid heart rate, things like that. Methylxanthines, theophylline is what's most commonly used in this country. Theodor, Unifil, Theo24, Slowbig, Quiberon. These are weak bronchodilators. They may have some anti-inflammatory effects. They have a high side effect profile when the dose is too high. Symptoms of headache, tachycardia, rapid heart rate, nausea. When the levels are too low, you have no effect at all from the medication. They're useful in some patients, very helpful in some, but others are not appropriate. A relatively new class of anti-inflammatory non-cortisone medications for asthma, the leukotriene modifiers, Singulair and Accolate. Xolutin was the first one to come out. That is a cyclooxygenase inhibitor. It is very cumbersome to take. You have to take it 4 times a day. It's not used very much. These other two are very helpful. Accolate is a good medication. You have to take it twice a day. There's some interaction with drugs, such as Coumadin. Singulair is also a very good medication for inflammation. And I think Dr. Friedman's going to be taking over here, talking about immunomodulation and subsequent